Hi, my name is Dr. Neil Talwar. I'm an assistant clinical professor at City of Hope in Upland, and I will be talking today about cancer screening as we age. So approximately 1 in 2 men and 1 in 3 women will develop some sort of cancer during their lifetime in the United States. As you can see from the graph below, cancer is a disease of aging, and 80% of all cancers in the US are diagnosed in people 55 or older, with the incidence peaking in the 8th decade of life. As people live longer, cancer screening becomes more and more important, and cancer screening gives us the best chance of finding cancers early and allows us to intervene before the cancer has spread to other areas. The leading sites of cancer incidence and death in males include the prostate, lung, and colon, while the leading sites and cause of death in females are the breast, lung, and colon. So screening in these cancer types is extremely important. And we will discuss the guidelines for screening in each of these malignancies. In addition, we will discuss cervical cancer, which is no longer one of the top 10 causes of cancer incidence or death in females. This is largely due to screening with Pap smears, and we'll go into this in more detail throughout the presentation. Cancer screening has been shown to reduce mortality in breast, colorectal, cervical, and lung cancers, and may also reduce mortality in prostate cancer. So in 2021, an estimated 281,500 women will be diagnosed with breast cancer in the US, with an estimated 43,600 deaths. Mortality for breast cancer peaked in 1989, but the death rate has declined by 41% by 2018 due to early detection with screening modalities, including mammograms, and also improved treatment options. The biggest risk factors for breast cancer are increasing age and female gender. The screening modality that we use is mammography, which is a low-dose X-ray that can detect breast cancer at an early stage. It has a sensitivity of about 80%, 87%, meaning about 13% of cancers can be missed on mammogram. Mammograms can also detect abnormalities that are not cancerous. About 12% of all women have abnormal mammograms, with only 5% of these women actually having breast cancer. Therefore, screening can carry risks, including unnecessary biopsies, overdiagnosis of precancers that would not have caused any harm, anxiety, and increased healthcare costs. So this is a little bit of a busy slide, but as you can see here, multiple societies have recommendations on breast cancer screening. They're all slightly different. I will give a general overview of the recommendations for women that are at average risk for developing breast cancer. This means women without any specific genetic syndromes or strong family history who may need earlier screening or more aggressive screening modalities. So for women from ages 40 to 49, we individualize who should start screening, and women who would like to start screening, knowing the potential risks, should have mammograms yearly or every 2 years. At age 50, mammography should be started for all women and should be performed at least every 2 years until age 74, with some guidelines recommending screening yearly. Clinical breast exams should not replace mammograms as screening modality, and MRIs are typically not recommended for women at standard risk given the high false positive rate. In women aged 75 or older, the recommendations for continued screening should be individualized. The decision should be shared decision between the patient and the healthcare provider, as well as the patient. The decision should be a factor in individuals' health status and life expectancy. And in those whose life expectancy is less than 10 years, the recommendation at this point would be to stop screening for this population of people. So let's move on to colon cancer screening. An estimated 104,000 cases of colon cancer with 45,000 cases of rectal cancer will be diagnosed in 2021. Approximately 52,000 people will die of both colon and rectal cancer this year. The colon cancer incidence has declined more than 1/3 since the year 2000. This is largely due to increased screening modalities. Death rates have also declined by 55% from 1970 to 2018, also due to increased screening. Screening can detect cancers at an early stage and can also detect precancerous growths called polyps, which can be removed before they become cancerous. Typically takes about 10 years for a polyp to turn into a colon cancer. So these polyps, when they're removed, can prevent the colon cancer from forming in the first place. So what are my options for screening for colon cancer? There are several approved modalities for colon cancer screening. A guaiac-based fecal occult blood test, also called an FOBT, or a fecal immunochemical test, a FIT test, which detect blood in the stool, can be used yearly as a screening modality. A newer test called the multi-target stool DNA test, which you may have heard of as Cologuard, combines fecal markers for hemoglobin or blood, and also DNA mutations that can be picked up in the stool. These tests can be performed every 3 years on one stool collection sample. If these are found to be positive, or if the FOBT or FIT tests are found to be positive, a colonoscopy would be indicated. Another potential screening modality is something called a flexible sigmoidoscopy. A flexible sigmoidoscopy is also similar to a colonoscopy, but it does not look at the entire colon. It only looks at the rectum and the lower part of the colon. And it can be performed every 5 years alone or in combination with the FOBT or FIT test. The advantages of the flexible sigmoidoscopy compared to the colonoscopy is that the preparation is easier for the patient, but it is noted that colon cancers on the right side, which have an increased incidence in elderly patients, may be missed by flexible sigmoidoscopy. Another modality is called CT colonography. This is a low-dose CT scan that can be considered every 5 years, but this can miss small polyps or cancers. Among all of the screening tests, colonoscopy is the gold standard and has the highest chance of detecting colorectal cancer and polyps. It also has the potential to detect and prevent cancers by removing the polyps prior to them becoming cancerous, all in one single procedure. Colonoscopy is recommended as a screening modality in all patients who are unable to undergo this test. The downside of colonoscopy is that the prep, and then it can be a little intensive, and the fact that it is a little bit more invasive than some of the other screening modalities. So who should get screened? In October 2020, the US Preventative Services Task Force, or the USPSTF, updated the recommendations to initiate screening at age 45 rather than the previous recommendation of age 50. This was based on a higher incidence of colon cancer being seen in patients in their 40s. So you may have your doctor telling you to go for colon cancer screening at an earlier age now. Screening should be continued at least every 10 years until age 75. Between age 76 and 85, it is recommended that you talk to your doctor about whether continuing screening is the right thing for you. Screening is not recommended after age 85 for most individuals. However, as we live longer, there should be a shared decision with you and your provider. So lung cancer. An estimated 235,000 cases of lung cancer will be diagnosed in the US, with 131,000 estimated deaths. This is currently the biggest cancer killer in the United States. The incidence and mortality have been declining since the mid-1980s, given reductions in smoking. However, it remains far the largest cause of death in both men and women. 80% of lung cancers are attributed to smoking, and there's a 25 times higher risk of getting lung cancer in smokers as compared to non-smokers. The symptoms of lung cancer do not typically appear until the cancer is already advanced. And therefore, screening has been recommended by the American Cancer Society since 2013. Risks of screening for lung cancer can include false positives, leading to biopsies, anxiety, and increased healthcare costs. So how do we screen for lung cancer? So a large study in the US showed that screening with a low-dose CT scan reduced lung cancer mortality by 20% compared to a chest X-ray in current or former heavy smokers. With low-dose CT scans, there's minimal radiation exposure, so the risks are low. Low-dose CT scan can detect small cancerous or precancerous nodules in the lung, which can be removed surgically or treated with radiation before they grow and spread. The thing about lung cancer screening is that it's fairly new, and the awareness of lung cancer screening is extremely low. One survey showed that 84% of those eligible for lung cancer screening were not aware they should be screened. There's also a low awareness of screening recommendations in the medical community amongst a lot of physicians. So many physicians do not even know to send their patients for lung cancer screening in the first place. So I think this is very important that patients be educated so that they can bring potential screening up to their provider. So who should be screened for lung cancer? Original recommendations for lung cancer screening as per the American Cancer Society in 2013 were that yearly screening with a low dose chest CT in patients 55 to 74 was indicated. These were patients who were actively smoking or had quit within the past 15 years and had a smoking history of at least 30 pack years. A pack year means that you smoked 1 pack a day for at least 30 years. Similarly, it could be half a pack a day for 60 years or 2 packs a day for 15 years. That all gets you to 30 pack years. Now, there's an updated screening guideline as of July 2020, as per the US Preventive Services Task Force that has just come into play. And this has expanded who we would screen for lung cancer. There's still going to be yearly screening with a low dose CAT scan. However, now the ages would be from age 50 to 80, and the smoking history would be less. So it's now patients who have smoked for 20 pack years rather than 30 pack years. And it's still in patients who are actively smoking or quit within the past 15 years. So if you do meet any of these criteria, it's very important that you speak to your doctor, as lung cancer screening can save lives. Prostate cancer will be diagnosed this year with an estimated 34,000 deaths. The incidence in prostate cancer spiked in the early 1990s due to increased screening and has declined since that time due to a change in the screening guidelines. We're actually screening less in prostate cancer now. At the same time, prostate cancer deaths declined by about 50% from the mid-1990s to the mid-2010s. PSA screening has been shown to reduce cancer mortality. However, it can lead to a high rate of overdiagnosis with routine screening of men that are at average risk. So all men should be educated of the benefits and risks of screening prior to making a decision to be screened. The risks would include detecting disease that would never have caused any symptoms or harm, which would lead to unnecessary procedures such as a biopsy and may even lead to treatment of the prostate cancer, such as with radiation or surgery. So the potential side effects of treatment come into play here as well. So who and how should men be screened for prostate cancer? So all patients aged 50 years or older should have a discussion with their provider regarding the benefits and risks of prostate cancer screening. If you choose to be screened, then screening should occur either yearly to every 2 years until about age 75. For patients with family members diagnosed before the age of 65, and for African-American men, the discussion for prostate cancer screening should start earlier at age 45. This is because there's an 80% increased risk of prostate cancer in African-Americans compared to non-Hispanic Caucasians. From age 76 to 85, you should speak to your healthcare provider to decide whether continuing screening is right for you. And the general recommendation for patients 85 and older would be to discontinue screening. In 2021, an estimated 15,000 cases of invasive cervical cancer will be diagnosed, with about 4,200 deaths. Death rates have dropped about 50% since the mid-1970s due to early detection through screening. Almost all cases of cervical cancer are caused by HPV, which is a virus that can be sexually transmitted. The American Cancer Society recommends routine vaccination between ages 9 and 26 for all patients who have not been adequately vaccinated. Unfortunately, the immunization rate remains low in the US, and HPV vaccine can protect against established infections or all types of HPV, and they can prevent cervical precancers from forming. Screening can prevent cervical cancers as well through detection and treatment of precancerous lesions, which are detected far more frequently than invasive cancers. Most cervical precancers develop slowly, so cancer can usually be prevented if an individual is screened regularly. The Pap smear is a simple procedure in which small samples of cells are collected from the cervix and examined under the microscope to see if there's any abnormalities that they can see. The HPV test can be done on the same sample that's taken with a Pap smear, and it can detect HPV infections that are associated with cervical cancer risk. So who should be screened? Women ages 21 to 29 should have a Pap test every 3 years. And starting at age 30, women should have a Pap test and an HPV DNA test every 5 years, or a Pap test alone every 3 years. At age 66, women can continue screening similarly to the guidelines for patients 30 to 65, or they should stop screening if they have had 3 or more consecutive Pap tests in the past 10 years, or 2 or more consecutive negative HPV and Pap tests in the past 10 years. In addition, women who have had total hysterectomy can also stop screening. So in conclusion, for breast cancers, we should start screening with regular mammograms at age 50 and consider starting screening at age 40, but this should be a discussion between you and your healthcare provider. Screening should be continued until age 74, and you should discuss the benefit of continued screening past age 74 with your doctor. For colon cancer, all patients should start screening with an approved test starting at age 45, with colonoscopy being the gold standard every 10 years. This should be continued until age 75, and you should have a discussion with your provider regarding the benefit of continued screening past age 75. Screening should be generally stopped at age 85. For lung cancer, again, there is a low awareness of screening amongst the general population as well as amongst healthcare providers. All former or current smokers between age 50 and 80 should speak to their healthcare provider about lung cancer screening with low-dose CT to see if you qualify. In terms of prostate cancer screening, all males greater than 50 should consider screening with a PSA level plus or minus a digital rectal exam. They should discuss continuing screening. At age 75, you should discuss with your healthcare provider regarding continuing screening. In terms of cervical cancer, patients should start screening at age 21 and should have Pap smears every 3 years until age 29. From ages 30 to 65, screening can be continued with every 5 years with a Pap smear plus an HPV test, or a Pap smear every 3 years alone. At age 66, it would be indicated to stop screening if you have 3 or more consecutive Pap tests that are negative in the past 10 years, or 2 or more consecutive negative HPV and Pap tests in the past 10 years. So bottom line, screening does save lives, and it's very important for us to be aware of these screening modalities and speak to our doctors about cancer screening. Thank you.